So off-pump surgery, that's what I do particularly. So I'm a surgeon, a trainer, a proctorate, and I'm published on it. So it's something I've been doing. I came from, this accent isn't of course English, I came from Northern Ireland to Liverpool because I wanted to learn off-pump surgery, and I sort of stayed the last decade and a bit. So it's relatively controversial. There are many opinions, and those who give them are opinionated. And there's generally some truth in what they say and some untruths. And unfortunately, it's quite muddy. Some of the studies are excellent studies of bad surgery, some are just bad studies, and we'll sort of go through that. In terms of what's done in the UK, it's normalised at a number of UK sites. So I work at Bristol, for instance. Most centres you just don't see it, so no choice is offered. And you as trainees, I would say a predominance of you haven't even seen off-pump surgery. So how can you know what is good, what isn't good? Hence, this is the trends in the UK now. So I've stopped in 2018. This was Angeline paper. 2008 was the peak year where just shy of 20% of cases were being done off-pump, and that has sort of slipped to 7.3, I think, in 2018. And it's effectively a handful of people doing 100% of their work off-pump is what we have now, and most others doing zero, and most units doing zero. So if you've got a horrible patient turns up, their options are limited in many trusts, unfortunately. My first day was 2 off-pump cases, total arterial, as a locum consultant. But I had 5 other consultant colleagues who all did similar things, so it was dead easy for me. If you're working in a lone unit, it's quite interesting to try and get it past your colleagues. I did this little review a few years in a row, and I've stopped doing it now because there's tens of thousands of articles. You can't keep up. There's multiple per day are being published. A huge amount of information that you can assimilate. Breaks down into 2 main types: randomised information and the non-randomised. Non-randomised first. Generally large data sets, some of them really quite enormous. There are attempts made to post hoc match the groups to try and get some meaningful information out of it. And they have all the usual problems with respect to data. So the New York registry started quite small, 36,000 versus 14,000 on versus off. Short-term outcomes are better. California registry, 44,000 versus 13, lower mortality. The STS database from Puskas is quite published in this area. Lower crude mortality, lower matched mortality, lower MACE. The Emory database was only 7,500 versus 7,000, again better off pump. Through time, the conversion rates have been getting smaller. The STS database 2 was quite big. It was 690,000 patients versus 186,000, and showed a considerable difference, particularly in low mortality with high risk patients. And when I went to Liverpool, hand drawn on the whiteboard of my boss was the graph that not showing above 2.5% STS score, your risks were better if you were off pump. First UK publications mine, we looked at 13,000 patients. Short-term outcomes were slightly better, long-term outcomes were identical. That was the first long-term paper showing identical outcomes on versus off. The second UK paper was a small one from Bristol looking at diabetic patients particularly, and they had an exceptionally low conversion rate of well less than 1%, and identical 10-year survival and lower first early morbidity. The US inpatient is an enormous study. You thought a million was good, they've got 199,000 patients in that one, and that's very clear. If you do a lot of off-pump in your hospital, or you yourself do it, your outcomes are better than on-pump. If you're a low-volume surgeon, a low-volume hospital, your outcomes are worse. I think it's an excellent evidence of you should not dabble. Whatever you do, do it to your, to full of your ability, or you're going to make mistakes. And the last one's a sort of smaller propensity score match, looking at 80-year-old patients and above, less stroke, but more renal insults, which is hard to tell exactly why that. Randomised data, generally smaller, the quality is variable, and the results are mixed. Bristol were a leading light in off-pump, and so there's small studies that start. BHACS, say ACAS, was only 200 patients in each arm. Lower early mobility, similar 1 to 3 year outcomes. Ruby is the big beast in the room. 1,500 patients in each arm, and effectively the outcomes are worse for off-pump at 1, 5 and 10 years. There's a lot of contention around that study and how qualified you needed to be an off-pump surgeon in that study. Looking at coronary and art and go cavity, where they had actually experienced off-pump surgeons, the outcomes are the same or better for off-pump surgery, depending upon the metrics you look at. I think Ruby is an excellent example, as I say, of an excellently conceived and run surgeon study, which was undertaken by surgeons who weren't that great at the procedure, unfortunately. The non-touch at the end is a meta-analysis of a number of different off-pump techniques, comparing off-pump, non-touch versus standard touch versus on-pump, and there are basically huge differences. The less you touch the heart, the less you touch the aorta, the breathing rates are lower, bleeding rates are lower, less stroke, lower mortality, lower renal pathology, and frequently the anti-aortic was better than touching the aorta at all. So the conclusion I come to this is there's really a discord between what's randomised out there and what you see in a real world experience. I think there's very clear evidence that the more you do something, the better you are at it, and that's across all surgical specialties, not just cardiac. I think there's clear evidence that the less you touch the aorta, the less you clamp it, you sidebite it, the more likely you are to not cause trouble. I think the overall benefit is probably quite small. So if you're a good on-pump surgeon who halfway through your career decide you want to try off-pump surgery, there will be a learning curve, there will be issues you will address, and probably it's not worth your while becoming an off-pump surgeon. Pardon me. The greatest benefit is the most difficult cases. So I do off-pump for everything, and the straightforward cases are straightforward. The more difficult cases, I'm not doing something new. I'm not doing a hard thing for the first time in 6 months. I'm just doing my normal stuff, and that probably gives greatest benefits for those patients. And about typically 40% or more of my cases are multi-arterial. I think there's great benefits there for less than, we're doing more than a single graft. Yeah, so if you don't have an off-pump surgeon in your hospital, what's going to happen to this patient who needs grafts? Who's going to do that? It's going to be straight to PCI, whereas me and colleagues like me would get a phone call, and what we would do would be our normal operation. We wouldn't do anything different. It's just a routine day. Yes, there are risks that are higher, but the technical aspects of the operation are no different from normal. So what do I get? The aortic calcification is shown. There's some evidence that not going on bypass means you're reducing down your renal insult. Those who get prior strokes, those with liver disease, because there's some evidence that that is protective. Various other disorders. And conduit issues at the bottom is because, like we just heard, you can take two bits of conduit 15 centimeters long and do as many grafts as you want. The facility of doing sequential grafting is something a lot of surgeons don't do. Top end, bottom end, repeat over many, many years. When you have conduit issues, you have to think your way through a side-to-side anastomosis. If that's part of your normal armamentarium, it's just normal, not difficult. So this is, unfortunately, we didn't have this published. Off-pump's cheaper. The consumables are about the same price, but they have less blood, they're in the hospital for less time. The risk-adjusted mortality is better, especially those with poor LVs. They're in intensive care for a shorter period of time, and we give them less chemicals because of disrupted myocardium mass. So, what are the indications? Surgery, that's it. There's nothing fancy about it. There's no, I don't exclude anybody. Contraindications, a little bit more nuanced. When I start a case, get the conduits ready, I'll pick up the heart to assess the targets. I'll be a little bit less gentle than I can be, and that's a sort of deliberate test. Does the blood pressure cope? If it doesn't cope, does it bounce back quickly? And if it does either of those two, then we're fine, we'll proceed on with the case. If the heart doesn't recover, or it's a big flabby dilated heart that's more sort of volume size rather than the ejection fraction, because you get a very poor ejection fraction which copes very nicely. So there's as well a measured response. You start with some chemicals. Can your anaesthetist colleague help you out to support the heart through? If not, I'll then move on to putting a balloon pump in and staying off pump.